our guest speaker, Dr. D. So we welcome Dr. D from Care Partner. And Dr. D, could you unmute your microphone?
Just didn't want to until we were ready to talk. Since
I see. Yeah. Okay. Since you're in, and we'd like to thank you to join us. And my name is Gemma Kim, and I'm a program manager. And then I'd like to introduce our CEO, Holden Leung. So maybe Holden can say a few words. Welcome, Dr. D. Yeah.
Nice to meet you, Dr. Dis, virtually. I hope we have a chance to meet each other. I was asked to do some sharings about our program, and then so when I see your face kind of show up on the camera, I try to cut short about the presentation. Hopefully that won't kind of slow you down, but hopefully my sharing is that really appreciate that. I think we are human service provider. People know that we didn't earn much, but it's the reward that from serving others. So hopefully,
the things you were saying apply to all of us, and that's why we do the things we do.
Yes. Welcome.
Okay. So now we can start. Go ahead and start your presentation. So once we have your PowerPoints ready. And so whenever you need to move on to the next slide, you can just say next slide. Then Vivian will do the showing the slides.
Okay.
All right.
All right. Well, I'm Bill Dronkowski. I'm a physician who works with Care Partners Hospice, but I also do palliative care consults both outside of the hospital and at Hillsborough Tuwality Hospital. I'm going to talk to you about things to look for when patients might need to be considered for referral to either palliative care or hospice and what the differences between the two are. Go ahead and start the slides.
So Vivian. Scroll down.
Next one.
Next one. Yeah.
And okay, next slide. Okay, well, palliative care includes hospice. So all hospice is a type of palliative care, but not all palliative care is hospice. Traditional hospice handles a very small number of folks that are estimated to have a life expectancy of 6 months or less. And then we have extended our palliative care with focused care programs to try to include caring for people that may have a little bit more time than that and who still have a functional status of life where we think we can improve that functional status. Next slide. Okay, palliative care is an interdisciplinary medical specialty, meaning that it includes doctors, nurses, social workers, and clergy. And it has the goal of preventing and relieving suffering, both for the patients and their families, mentally, physically, spiritually, and existentially. And the second goal is to support the best quality of life for the patients and their families for the longest period of time we can while they're suffering a serious illness. Usually that is a serious illness that's not going to be curable. It'll either be chronic or it may be terminal. Next slide. When is it appropriate to think about palliative care for a friend, family member, colleague? It's when that patient or person has developed an unexpected serious illness diagnosis. Examples of that are a stage 4 cancer, that's one that's not resectable, or surgically curable. Cancers that are so advanced and have had multiple attempts at chemotherapy and are not responding well. And then other diseases that we don't have a very good treatment program for, such as ALS, and in some cases, COVID, when it is in a high-risk population with very advanced disease. Certainly not all of them. There are many young people that do just fine with that illness. The other group of diseases are chronic diseases like heart failure and COPD that will continue to progress and eventually will probably cause the patient's death, although something else may intervene in between. When they progress to the point where they're having multiple ER visits or hospitalizations, usually we say about 3 within 6 months, then it's time to consider whether the patient is actually becoming weaker and functioning worse after each of these hospitalizations, or they're actually improving. And then other diseases that we're seeing a lot of now and that are becoming more and more of what we have to deal with is moderate to severe Alzheimer's and other dementias such as vascular, frontal lobe, and Lewy body dementia. You have to remember, dementia is not just a memory problem. It's an incurable, progressive brain disease that will be fatal if they do not have another disease that leads to their death first. Now, it has various progressions. Some people, it will rapidly progress in a matter of 3 or 4 years. The patient may become unable to feed themselves and at risk to aspirate. Other people can go on 10 or 12 years with a progressive dementia. So we have to observe dementias first to decide what kind of course they're taking before we can decide whether they're appropriate for palliative care or not. Next slide. One of the things we have to remember, and that you may want to know if you see these kinds of people where you're thinking, boy, this person really ought to be looking at what their potential choices are, is quite often people don't want to discuss their prognosis, their longevity, or their life expectancy is. In a survey done in the Annals of Family Medicine, 44% of the people didn't want to know their prognosis, even if their life expectancy was less than 2 years. 17% didn't want to talk about it, even when they knew their life expectancy was less than a month. That is just the general population, and then you need to incorporate those statistics, cultural factors of how death is viewed and how it should be addressed, depending on the culture that a patient comes from. In some cultures, it is almost taboo to discuss death in front of a patient. Prognosis is not required to have the conversation, the discussion with a patient about what they want their future plans to be. The focus should be on helping manage the patient where they are now and helping them view and discuss where they wish to be in the future and how they wish to be cared for. Often it's done best with family. Sometimes it's done with family alone in certain patients that don't want to have it discussed in front of them. A palliative care discussion by a palliative care consultant who is versed in this may be very helpful for framing it in the right way in order to have it acceptable to the people you're discussing it with. Next slide. Requesting a palliative care consult. The idea behind them are consults are designed to maximize the individual attention and interaction outside the normal clinic schedule and structure. I do these in the hospital and patients' rooms, or sometimes in a family or consultation room where there's more family members that can be obtained. And when I do it as an outpatient, I do it wherever the patient is living, whether they're living in the home, an assisted care, a memory care, a nursing home. We try to do it in the most natural circumstances possible. Topics that are included in these include the individual person's and the family's view of their current situation and the treatment history, what their expectation, hopes, and concerns for the future are, something we in medicine call goals of care, which is involved in advanced planning, but consists of asking what the patient finds most important in their life that they want us to address, and addressing those first. Oftentimes, even a patient who would not say they want to be a do not resuscitate, their goals of care are keeping their dignity and remaining comfortable. It's not how long they live, it's how they live that's important to them. And then discussion of symptom management and support to help maintain as much as possible the activities of daily living. Next slide. For our hospice and over at Tuwality Hospital, now OHSU Hillsborough, I am the palliative care consultant that most likely they will call. I'm board certified in internal medicine and in hospice and palliative care, and have about 30 years of experience in critical care, general medicine, and geriatric care that I bring to this experience and that I think is very important in helping gauge how to form and follow the conversation. I'm not new to this game. The criteria for a palliative care consult by care partners as an outpatient is somebody lives in a 5-county greater Portland area, they're 18 years of age or older, they have one or more serious illnesses, and an individual family member or primary treating physician has requested the consult. Anybody can request the consult. If they're in the hospital, I can see people that don't necessarily reside within the Portland area. A couple of weeks ago, I saw a young woman who was from Coos Bay who was up here when she got ill. So a palliative care consult may be followed by palliative care management, and that includes management of specific conditions, services that's coverage by insurance depends on the insurance policy. Palliative care can be provided, unlike hospice, in patients who are still seeking and being actively treated with life-prolonging, curative, hopeful treatment programs. In the Portland area, Regents Blue Cross and HealthNet both have palliative care coverage in their insurance plans. Unfortunately, Medicare and Medicaid do not. They do cover hospice, however. Next slide. Things to remember when you're talking to a family about a serious illness, whether you're trying to bring up that maybe they want to ask for a palliative care consult, or whether it's me doing a palliative care consult, is you want to make sure that you have had access and looked at all the information that's available and that it's accurate. Too often people are making advice based on inadequate information, and we need to have adequate information before we start. Determine who should initiate the conversation and what family members or support people should be present with the patient to discuss it. If there are new people in the room at the time of discussion, they all should be introduced. You need to assess the perceptions and openness. You need to find out how much the individual and family members know and understand of the condition, how serious the condition is, and how serious they think the condition is, and what they know or what they think about how it could affect the future. Next slide. You want to reinforce what they do know that's correct, clarify things that may not be understood well, clarify your recommendations in your discussion by continuing to ask whether it makes sense, whether they understand, maybe even have them repeat it back to you in their own words to be sure that they truly understand what's going on. You need to address emotions with empathy. You need to observe the reactions people have and be courteous to those. Allow periods of silence. People need time that they don't necessarily talk when they're absorbing all this, and allow them to express their emotions and be supportive of that. Identify positive coping strategies and help encourage them, and include various sources of support within the community or within their family and friends that they can lean on. Next slide. One of the things that wasn't present in that slide, I think it's important, and I make sure when I'm doing a palliative care consult, you need to have adequate time and you need to have a private place where you'll be uninterrupted. This is not the kind of discussion you can have with people running in and out of the room with beepers or telephones going off. So when I make a consult, I try to make sure I have at least 2 hours available. Sometimes the consult takes 25 minutes. More often it takes an hour to 90 minutes. It sometimes will take longer than that. I don't ever want to interrupt or stop a family or a patient when they are talking to me about what their future is and what their hopes are. They need to have time to express themselves. Now, hospice is a form of palliative care that was designed and created, and in this country is defined by the Medicare benefit, which most other insurance companies follow. It is in residence care, meaning it happens wherever the patient lives. Very rarely are patients in inpatient hospices. Usually they're in their own home, a foster care home, a nursing home, a memory care center. Wherever it is they reside, that's where the care is supplied at. It's cared by an interdisciplinary team. The team consists of an RN case manager, and they are the ones who carry the heaviest weight in this program. Their responsibility, it's their responsibility to coordinate the care of their patients. They're seeing the patients anytime from 1 to 3 or more times a week as needed for the situation. A physician, sometimes the PCP, often a physician who's a hospice physician or medical director with skills in this area. They have a home health aide, a medical social worker, a spiritual care counselor or chaplain, and volunteers. Part of the hospice benefit includes not only paying for all those people in the team at no cost to the patient, there's no copay when it's on Medicare, but also any medical equipment, any supplies, and any medications that are required for treatment of that disease. In addition, certain specialist services such as art and music therapy, RT, and OT are sometimes covered depending on the situation and the hospice. One thing that I have heard said, and that is true, if you've seen one hospice, you've seen one hospice. So if a patient is ever looking at hospices and interviews a hospice and it's not to their liking, they should talk to another hospice, because some hospices are far more open in their interpretation of what they can supply than others. Predominantly, and this is some of my prejudice, I think that nonprofit hospices are going to be more open to supplying more care than for-profit hospices, because none of their money is being shunted to pay for stockholders. It's all being respent on patient care. Okay, next slide. To be eligible for hospice as opposed to palliative care, a patient has to have a terminal illness with a prognosis or life expectancy of 6 months or less. Now, that is statistical, so that if I took 100 patients, 50 of them may live to be 2 years old, and some of them may live to be, may only live 6 weeks, but I estimate that 50% of the people with that degree of disease and with the comorbidities or secondary diseases they have would probably die within 6 months. I've had patients on hospice 4 years, okay? They do not lose their benefit. There's no penalty, as long as when I look at them in the best clinical judgment, I would say they probably are gonna live about 2 years. That you have to have 2 physicians willing to attest to that, usually the hospice medical director and the primary care physician. Agreement by the patient that they're going to not try to seek or participate in curative or life-prolonging therapy. That doesn't mean they can't have life-prolonging therapy if it's for symptom control and it happens to help them live longer. We know most hospice patients actually do that, but they can't be getting chemotherapy while they're on hospice. We want them to agree that the priority is outpatient treatment. We want to try to keep them out of the hospital to give them a better quality of life and keep them at home. So when they get sick, they don't call the hospital or 911 or call an ambulance. They call the hospice nurse, and we try to take care of them in their home. 24/7, we will come out there if we need to help them be comfortable and control their symptoms in their home. Next slide. These are myths about hospice that people have. Once people go on hospice, they die sooner. That is not true. In fact, there have been multiple studies that show that cancer and heart failure patients actually live longer on hospice than people not on hospice, perhaps because they have more of a will to live when we control their symptoms well and they're feeling they have good quality of life. About 15% of patients who come onto hospice are actually discharged alive because they get better on hospice because of the intensive nursing care and follow-up we can give them. We can do things that regular doctors and regular home health can't do. Hospice can't go back on treatment. Not true. At any time, a patient has the ability to revoke hospice. So if there's a new treatment that comes up that is very promising for the disease they have, a patient can revoke hospice, attempt that treatment. If it doesn't work, they can come back to hospice later at no penalty. On hospice, all medications other than pain medicines are discontinued. We will maintain whatever medications the patient wants to maintain as long as they're not active chemotherapy drugs for cure. Sometimes I will encourage patients that the drugs they're taking may have more side effects than the chance of them giving them improvement, but it's always the patient's choice if they discontinue or not. Patients can't continue to see their own physicians. Again, not true. Although the hospice physician will be involved in their care, they have the right to see their primary and their specialty physicians if they need to. People must elect to do not resuscitate. Not true. The vast majority of hospice patients at some point decide to do that, but some come on hospice before they're ready to make that decision. And hospice is not needed if someone has in-home care. Again, these are very specialized nurses and a specialized team that provide care that a home health team or other hired outside nurses do not have the training to supply. Next slide. Oh, there that is. Problems that can occur when hospice is delayed. The person can have additional suffering that they didn't need to have. Family members may not get the support that they require. That includes the financial support that I mentioned. Families may wonder if their loved ones suffered needlessly and have guilt feelings about it. Timely medical and legal decisions and interventions that the patient probably needs to be thinking about and accomplish may be delayed and not done. That can be very frustrating to families later. And important end-of-life goals are not met because nobody has actually made those goals of care that I discussed. Trauma from recurrent ER and hospital visits could have been avoided. Most patients, by the time they get to this point, do not enjoy being transferred back and forth to the hospital and the emergency room. If we can take care of them and improve their symptoms at home, the vast majority would rather live more of their life at home than spend weeks and extra days in the hospital. And that's the end of my organized talk, and I'm available to take questions you may have.
We just to notice that Krista is joining this presentation. So Krista, could you introduce yourself and say a few words? Yeah.
Absolutely. I'm sorry, I saw the message that you were going to be starting at 11:30, so I delayed the sign in.
Mm-hmm.
But I am the director of community partnerships at Care Partners, and my job is to connect with all the different agencies in our community, people like yourselves, people in clinics, in long-term care communities, and help determine what the best approaches would be for the care of their particular populations. So we have been talking to you all for a couple of years now. A lot of what we do at Care Partners has historically been focused around care of cancer patients. But since Dr. Dronkowski joined us, we have also rolled out some specialty care programs that we call focus care, specifically for people with heart failure and chronic lung disease. So these are things that, you know, we'd like to talk to you a bit more about at a later time, but there are definitely some interesting options that no one else has here in the Portland area. We feel like they're a great bridge because many people, as Dr. Dronkowski pointed out, don't qualify for palliative care. But there is a version of hospice, again, this focus care that really does provide more benefits than a lot of people realize. So that's a topic for another time.
Yes. Thank you so much for Dr. Dronkowski. I don't know if I pronounce it right.
Everybody just calls me Dr. D or Dr. Bill.
Okay.
That's absolutely fine.
Okay.
I'm not offended at that by the least. And the one last thing I'd say is, you know, I do this because I have a passion for it. I've taken care of people for 35 years in medicine, and you know, the first 25 traditional medicine, and then over the last 10 years or so, I've transitioned more and more to doing hospice and palliative care only, because my patients got to the age they started saying, "Doc, I don't want to go through that one more time." And so the thing that I say to you is, I am more than happy to do a consultation on anybody who you think might benefit from palliative care or hospice and might need it. If it's not that time yet, if it's 2 more years before they need it, that's fine, but at least we can bring up the subject and they can think about it. And I never look at it as a waste of time, because I love the opportunity to sit down and have a cup of tea with patients and talk about what's important in their life, which is usually how I start my conversations. So anybody that you guys think might benefit, please feel free to call us.
Yeah. Thank you so much for joining with a short notice, and we feel so grateful to have Dr. D and Krista on this presentation, and we really appreciate And some of the staff and most of our volunteers. And so this presentation has been really helpful and great information. And I know this is a short time and we can cover, you know, all the detail, all the information, but this is like our beginning, like just to taste of or just getting the information from the service. And then we hope that we continue to have presentation or trainings by you, and then we are eager to learn, and we're eager to really learn and provide this information to our patient and family members. And so I want to just open up for the question and answer. So if any of you have any questions, and please feel free to just unmute your microphone and asking the questions.
Hi, Dr. Dronkowski.
Well, hi.
You get the prize. Congratulations.
That was great. You did a, yeah.
I had a question about, I was just wondering, curative therapy and what is that? What is involved in that? Is that?
Curative therapy means a therapy that is aimed towards curing a disease. Now, heart failure, you can't cure. You can't cure COPD. You can't cure a dementia. And cancers after a certain place in time, many of them you can't cure. So for cancer, it means you're not going to do any more chemotherapy. We can do radiation therapy if it's for symptoms only to make them feel better. And in heart failure and COPD, what we found is the same therapy that you give to improve their symptoms actually prolongs people's life. So we give a lot of the same therapy that they give in the advanced heart failure programs. And I've even had patients from advanced failure programs that are awaiting possible transplant or awaiting a ventricular assist device come on hospice while they're waiting to see if they qualify for that, so we can control their symptoms. If they do qualify for it, then we have to take them off hospice.
Okay. Thank you.
Maybe I'll just add one thing, and that is that you may assume that someone who has a defibrillator device can't come on hospice. They can. We will definitely take them. The thing that is a prohibition for us is the VAD, the ventricular assist device, because VADs are extremely expensive to maintain and require repeat hospitalization. So those are not consistent with going on hospice. But defibrillators, that's fine. And we do take people, and we have a program to manage that.
So from the agency's perspective, hi, Kristin, and nice to meet you again. So I think when we first start talking about the program now, you know that we are a new program with our special focus to serve like people from the Asian communities. So from Dr. Don Walsh, so with your presentation, how you can like see how a program like us can partner with care partners to serve people who may not speak English or from different cultures. So what role or how are we going to address that gap?
I think the big thing that can be done there is that I'm Caucasian, and although I have a lot of Asian American friends and relatives, I don't speak any of the languages, and I don't know the culture as intimately as all of you do. Without being racially prejudiced, I think an awful lot of Asian Americans are very proud people, and those people do not like to reach outside their families for help. Sometimes they have difficulty talking about death and accepting death. That's true in other cultures as well. I think that's where your volunteers, both knowing the language and the culture, can maybe help these people see that we might be able to assist them. And we may be able to make their life better for whatever time they have left, whether it's 6 months or 6 years, so that they can enjoy life in their families and enjoy the joy of life. We're not about death. We're about the joy of life for as long as you can live it.
Mhm.
Well, then I think to be maybe more specific about next steps, we had talked about doing a joint presentation with Dr. Dronkowski and one of his colleagues who I understand also works with you is Dr. Yao, I believe.
Mhm.
So I think that might help potentially be a good first step, that there are, 2 clinicians, one of whom already has the history with you and with your population. And then we can talk about, based on the audience reaction and what people's interests and comments are, the best way to proceed from there. Because I don't think we want to make assumptions incorrectly. We'd probably be better off to get the real feedback.
Yeah.
And I think that would be so mutually beneficial. I can read a lot about Chinese and Asian culture, but I'm not going to experience it or understand it until I talk to people. And so I really think if I could work with another clinician and with you and your staff and volunteers, it could help make me a better doctor in the way I deal with patients from your culture, because I'll be more appreciative of it. I try hard, but the more experience I have and the more input I have, the better I'll do.
Mhm. Because I see your slide, that in your slide, you emphasize that the palliative care is an interdisciplinary approach. So for a new program like us, we are like recruiting and training new staff. We call them like cancer patient navigator. So they are kind of like in between medical social worker or volunteer. So that's why I'm looking for like, can we develop some training program so that we can train up our community, the cancer patient navigator become a team member working together. That may be something that I'm looking for.
I think that's a great goal. I'll tell you, I look at myself as a resource person and as a backup person, support person for my nurses and the home health aides, who are the backbone and the workhorses of our hospice program. They're the ones that are doing the day-to-day care people. They come to me with what they know the patient needs, and then I try to figure out how to get the patient what he needs. So it's we would not survive, either you or I, without our volunteers and our staff members from the bottom up.
Yes.
So Holden, we do have some education programs. We've got a specific, just like the focus care programs for heart failure and for COPD, we have a similar program for cancer, and it includes 4 hours of training that we provide to our staff members. So we have different training approaches, we have different content, and of course our clinical staff members would also be willing to just share, their own personal experiences, other things that your staff might find relevant. So maybe the best thing would be for you and Gemma and I to talk about what they would most find helpful, and then we can go back and look and see how to get that to you.
And just not to forget, among our focus care programs and educational programs we have is one on dementia. And that is one of the most difficult diseases for a family or a community to have to deal with, is watching the decline of somebody they love. And we certainly would be willing to share what we know about that area and how we approach it.
Yes, I think I look forward to seeing like how Gemma can follow up with Kristin about developing the right resources so that we can like have a joint effort to like address the issue.
We'd be most happy to do that. Thank you for the invitation and thank you for having us today.
Are there any other
Gentlemen,
questions?
yourself.
I saw Samantha's iPad came up for a moment. Did she have a question?
Oh no, I'm just participating by watching you guys.
Oh, okay. You know, because there's no such thing as a foolish question in this area. Those questions are oftentimes the most prominent in everybody's mind.
Yeah, I can tell you that we've had healthcare professionals who didn't know the difference between the myth and the fact on the hospice myths and facts slide. And some of them worked in hospitals. So please don't feel in any way shy about any of this.
Well,
Do you have more
I
questions?
am open to any of you, even
Mhm.
after this meeting is over. You can get our phone number from Gemma, and any of you have questions I can help you with, I am more than delighted to try to, because I have dealt with these issues in my own family and been through it a couple of times. And it is very hard to be a family member saying goodbye to a loved one, whether it's from heart failure, cancer, or dementia. And I have been through all of those.
Mhm.
Okay.
Not a easy training course to like have a life experience.
Yes. Yeah, I think that's true of many people who work in Care Partners. They came there because of personal experiences that led them to want to make a contribution. So Gemma, let me know. We can do some Q&A by email if appropriate, and I will follow up with you on some additional materials.
Okay. Thank you so much for all your support and time. And then we all appreciate you so much. And I know this is just the beginning of our conversation. So we'll continue to have a conversation and, you know, keep working together to make help our patient and family member to have a quality of their life and make their journey a little bit peaceful and easier. So I think that's the
I look forward to working with you more.
And I know
thank you so
Tracy does as well. She was on
Mhm.
paid time off this week, but she's looking forward to reconnecting with you all. Thank you.
Okay, thank you so much. Thank you,
Uh-huh.
everyone.
Bye-bye.